My name's Nicholas Verne, and I'd like to welcome you to this evening's ANMS Virtual Symposia, which is part of our medical procedure educational series. So before we get started, I'd like to share with you a couple of announcements. A reminder of our upcoming ANMS annual meeting on August 11th to the 13th, 2023 in Austin, Texas. Please note that the abstract deadline is April 1st, 2023. Also, our upcoming ANMS Fellows Advanced Motility meeting for second and third year fellows. This is August 10th, 2023, and the application deadline will be May 1st, 2023. So tonight, our ANMS Virtual Symposium this evening is entitled Pearls of Wisdom, Hydrogen Breath Testing. Our moderators are Dr. Jason Baker and Dr. Brooks Cash. Dr. Baker, over the last 20 years, has mentored and taught numerous allied health professionals who perform manometric procedures. His primary scientific areas of interest include anorectal physiology, innovative manometric design, and gastrointestinal health literacy. He is presented at numerous national and international annual scientific meetings. Dr. Cash is chief of the Division of Gastroenterology and Hepatology at the University of Texas Health Science Center at Houston, where he's also the Dan and Lilly Steering Professor of Clinical Gastroenterology at the University of Texas McGovern Medical School, and the endowed director of the Chow Erten Directorship at Memorial Hermann Hospital in Texas Medical Center. Dr. Cash is an international expert of a wide variety of gastrointestinal topics, and his clinical interests include brain-gut interaction, gastrointestinal immunology, and motility disturbances, colorectal cancer screening, Barrett's esophagus. He's recognized as one of the best gastroenterologists in Houston by the Houstonia magazine since 2019, and by a top doctor by Texas Monthly magazine since 2020. He is also a Rome Foundation Fellow and is a member of the Rome 5 Functional Bowel Disorders Committee and has authored over 200 publications. With that, I will turn this evening's program over to Dr. Baker and Dr. Cash. Thank you both for joining us.
Thank you, Dr. Verne, for the kind introductions. I welcome everybody tonight. Really looking forward to Coco's presentation on hydrogen breath testing, and I'm blessed to have this opportunity to co-moderate with Dr. Cash. And Dr. Cash is going to introduce Coco here in a second, but I just want to remind everybody, if you're going to have a question, if you could put it in the Q&A icon on the bottom of the screen, and Dr. Cash and I will toggle back and forth to present them to Coco at the end of her presentation. Dr. Cash?
Well, thank you so much, Jason, and it is an honor to be able to co-moderate with you, and I want to thank the ANMS for sponsoring this great program, and I especially want to thank our speaker, Coka Yip, for agreeing to speak with us. I think this is going to be a wonderful program and very illustrative, and something that hopefully we'll all be able to go back to and use over and over again. So let me introduce her. Dr. Yip has been, Coka Yip has been a GI nurse practitioner since 2007, and she's worked in the United States and Singapore. She joined the GI motility team at Cedars-Sinai Medical Center in 2018. She graduated with a Doctor of Nursing from the Southern California CSU DNP Consortium in August 2020. And in addition to her clinical practice, she also leads quality improvement projects. She precepts nurse practitioner students and is one of the Nursing Awards Committee reviewers at Cedars-Sinai Medical Center. And she's going to be speaking to us today about pearls and pitfalls regarding breath testing for gastrointestinal motility disorders. So with that, I will turn it over to Coka. Thank you so much, Coka, for doing this. We'll let you share your slides, and Jason and I will disappear and go silent for a little while.
Thank you, Dr. Cash, for such a kind introduction, and thank you both, Dr. Baker and Dr. Cash, to be my moderator tonight. Also, I want to thank the ANMS for the invitation for me to speak with you tonight. I'm very happy and excited to be able to share with you what I have learned on hydrogen breath testing over the last few years. So let me just make sure my slides are ready here. Now, hydrogen breath testing, pearls of wisdom. There's a lot of exciting things to talk about, and I only have about 25 minutes. So the objective today will be kind of broad, and they are somewhat superficial, and I just want to make sure I cover some of the basic knowledge, including what is a hydrogen breath test, the different types of hydrogen breath tests, the basics of like carbohydrate malabsorption and microbial overgrowth. And then we're going to go over the principles of breath testing, how to prepare for breath tests, and at the end, we'll talk about interpretations. So if a patient asks, what is a hydrogen breath test? The most simplest answer that I usually give them is if it's indicated for carbohydrate malabsorption, usually I'll tell them it's a test to tell whether or not one can digest carbohydrates such as lactose, fructose, or sucrose. Now, there are many other substrates out there, but these three are the usually most common ones that are available and are mostly documented in the literature. For microbial overgrowth, it is a test to check for microbial overgrowth, including hydrogen. Now, recently, we're able to test for hydrogen sulfide and then for intestinal methanogen overgrowth as well. There are different types of hydrogen breath tests for carbohydrate malabsorption. We commonly use lactose, fructose, as well as sucrose. For microbial overgrowth, we can use lactulose or glucose. It is important to know what kind of substrate we're using, such that glucose and fructose are monosaccharides, lactose and sucrose are disaccharides, and lactulose is actually non-digestible disaccharides. The reason that it is important is that it goes into the basics of carbohydrate malabsorption, because disaccharide will need to be first broken down into monosaccharides for absorption to take place. And then carbohydrates that are not digested and absorbed in the small bowel will undergo fermentation by the bacteria in the colon, which results into short chain fatty acids, carbon dioxide, hydrogen, as well as methane. And then it is the production of all these gases that usually yield a lot of symptoms such as abdominal bloating, abdominal discomfort, gas, nausea, and different kind of GI symptoms. Now, there are many different causes of carbohydrate malabsorption. And the more documented ones are reduction in disaccharidase activity and the small intestinal brush border level, such as lactase deficiency. Chronic pancreatitis can result in deficiency in pancreatic amylase. There could be conditions of absorptive capacity limitation, such as fructose, that is related to the GLU-T5 transporter. And then there's also decreased absorptive intestinal surface area, such as those in celiac disease. And just to point out that hydrogen breath testing does not test for celiac. I listed celiac here is just as a potential causes of carbohydrate malabsorption. Now, when we talk about what is microbial overgrowth, one thing that we really wanted to highlight is that it is not an infection. Microbial overgrowth, if we think about it, there are a lot of microbial and different kind of bacteria that lines our gut. We have more bacteria that lines our gut than we do with our human cells. So unlike the colon, our small bowel is actually relatively sterile. If you look at the picture on the right, at the different distribution sites of the small bowel, there's no more than 10 to the third colony forming units per ml of bacteria. As compared to the colon, there could be a lot more. So microbial overgrowth is mainly a dislocation of colonic bacteria that migrated up into the small bowel, and it's not an infection. Intestinal methanogen overgrowth is an excessive amount of methanogen arcadia in the small large bowel. For those of you who may not know, there is a recent terminology for methanogen arcadia because arcadia is not bacteria, so it's termed intestinal methanogen overgrowth. When we talk about risk factors for microbial overgrowth, it could be when we think of patient populations that might be indicated for microbial breath testing, we always want to think of stasis, and such as those who have post-surgical state, blind loop syndrome, ileocecal resection, anastomach stricture, adhesions, those who are on medications such as anticholinergics, narcotics that could slow down the motility of the gut, patients with pancreatitis, cirrhosis, pancreatic insufficiency, any kind of structural changes or defects such as small bowel diverticulum, fiber spread, IC valve resection, as well as small bowel dysmotility due to connective tissue diseases, diabetes that causing neuropathy of the gut, and post-infections such as irritable bowel syndromes with positive antifungal antibodies. Inflammatory states such as inflammatory bowel disease like Crohn's or radiation colitis or enteritis. Also, people who have a lack of gastric acid secretion, such as autoimmune gastritis and gastrectomy. So these are all at risk because of stasis, potential stasis. And then when we talk about signs and symptoms of microbial overgrowth, it could be a variety of symptoms, anywhere from like nausea without vomiting, early fullness. Some people may complain of fatigue. Some people may have brain fog. Weight changes could be loss or weight gain. Interestingly, people who tend to have methane tend to have constipation. That's mainly because there's a lot of literature out there that shows methanogen with the production of methane, it could actually slow down the motility of gut and cause constipation. On the other hand, hydrogen or hydrogen sulfide producing bacteria may cause potential enterocyte damages, results in diarrhea. Vitamin deficiency in the past they have been documented, but then more recently we have found out that it's not common to see vitamin deficiency in people with microbial overgrowth, and the earlier literature are usually those who have post-surgical changes such as Blind syndrome. Although sometimes we might see a low vitamin B12 level because of utilization by bacteria, and sometimes people may have high folate level because bacteria produces folate. Now, here's a simplified pathway of gas production by microbiome. On the left, we have bacterial fermentation of carbohydrate. And initially, during the fermentation process, hydrogen and carbon dioxide are being produced. And then, of course, there are, from there, it could be other kind of compounds and gases that can be produced too, such as that methanogens like to consume hydrogen and carbon dioxide to make methane, while sulfate-reducing bacteria like to use hydrogen to make hydrogen sulfide. The main thing you want to get out from this slide is that hydrogen and methane are exclusively produced by our gut microbiome during fermentation by bacteria. Our human cells are not capable of producing hydrogen and methane, and this is the backbone of hydrogen breath passing. Now, going into a little bit of physiology and basic principles of breath testing. As you know, when we give a patient a substrate, whether it is fructose, glucose, or lactulose, the substrate enters the stomach and then it travels down to the small intestine. Depending on type of excessive bacteria the person has, hydrogen or methane or hydrogen sulfide, and then being produced. And then these gases are being diffused into the bloodstream circulation. Therefore, it circulates to the lung. And then in our lung, the alveoli help us with gas exchanges, such as exchanging our carbon dioxide with oxygen, and then at the same time, hydrogen and methane are also being exchanged. And then the idea of breath test is that we're trying to capture these gases with the exhalation of the patient's breath. And then one thing that is important is that measuring the carbon dioxide is very important during these kind of breath testing, and it is mainly for alveolar gas adjustment. If we think about it, there, in a breath sample, the best way to increase the reliability of the breath sample is that we wanted to get as close to alveolar sampling as possible. And if we think about it, there's always residual or air that's left behind from the last breath inside our mouth, in the back of our throat, and as well as in our main airway. So how do we get to the alveolar gas sample as close as possible? Or how do we know if it's even as close as possible? So one analogy I like to use is, if you have an order for urine culture to check for UTI, you always want to educate the patient to, go ahead and, pee into the toilet, and we want to dispose of the first initial part of the void, and then we only want to collect the midstream, just so that we want to avoid potential contamination for the urine culture. Similar concept here. And then depending on what kind of collection devices or bags that your facility have, and then some of these collection devices have valve and different system that could help us with collecting as close to the alveolar breath sample as possible. For example, at Cedars-Sinai here, we use this collection method, where if you can see here, is the mouthpiece where the patient will blow into the mouthpiece. And then the initial 100 ml of the breath sample, we enter this plastic bag. And then the remaining air will enter this space here, where this is the actual air that we want to use for the actual analysis of the breath sample. We then will use a syringe here to draw out about 30 ml of air, and then we'll run it through our breath tracker analyzer. We, at our facility, we use the breath tracker. And with the breath tracker, it allows us to capture the numbers on hydrogen, methane, as well as carbon dioxide. Now, in terms of microbial overgrowth breath testing, there are two main substrates that we use. One is lactulose and the other one is glucose. There are a lot of differences between the two. One is that lactulose is a non-absorbable disaccharide, while glucose is a monosaccharide that is easily digested and quickly absorbed from the small bowel. And lactulose, on the other hand, is metabolized by gut bacteria in the colon. The dose of the lactulose is 10 grams per dose, while glucose is 75 grams per dose. Lactulose tend to have a higher false positive weight, it's especially depending on the person, whether or not there is a faster gut transit. And glucose, on the other hand, have lower sensitivity and higher specificity to the glucose. That's mainly because glucose being absorbed in the proximal small bowel. And I believe Dr. Baker had an article that was published in 2021 that compared the Rome criteria that came out in 2009 versus the North American consensus that came out in 2017, where they have compared the both protocol and used the glucose breath test for comparison, as well as the comparing the test we saw. Sorry, I'm going to drink some water here. With the one protocol, 50 grams per dose of glucose was used, and the cutoff was at 12 parts per minute, versus the North American consensus used 75 grams per dose of glucose and a cutoff of 20 parts per minute at 90 minutes in terms of a positive breath test. And because of the low sensitivity, high specificity to glucose, perhaps we might want to think about what the article may have suggested, using a cutoff at 12 parts per minute instead of the 20, but that would be later on, and see if we can have further studies being done on that. Now, in preparing for a SIBO breath test or microbial breath test, the North American consensus had suggested no antibiotic for 4 weeks, no laxative for 1 week, and no prokinetic drugs for 1 week. These are to optimize accuracy of the test. And then the diet the day before the breath test should avoid dairy and complex carbohydrate. And this is mainly to help prevent any kind of fermentable food causing elevation in baseline hydrogen levels. And then fasting after midnight is recommended by our facility, or 8 to 12 hours prior to the breath test as per the North American consensus guideline. There should be no cigarette smoking on the day of the breath test, because smoking tends to increase the stomach transit time, also increases hydrogen levels in the breath, and no strenuous exercises during the test, because potential hyperventilation from the strenuous exercises can reduce the hydrogen levels in the breath. Most of the patients that come in, usually they'll bring a book to read or bring the laptop to do some work on, so that's not an issue in our facility. And then for microbial breath testing, it should be a 2-hour test where patients should get a baseline sample. Then they will take the substrate followed by a glass of water, and then breath sampling every 15 minutes thereafter. Now, in terms of sample diet the day before a microbial breath test, usually protein is genuinely safe and they could eat the protein that they need. Carbohydrates are limited to white rice and potato. Beverage are limited to water, coffee, and tea with no cream or sugar. And then seasoning are usually limited to salt and pepper. And fats we allow olive or vegetable oils. Now, we talked about interpreting results of a breath test. That will be our next item. This slide looked very complex, but I just wanted to make sure you take home with knowing that a normal transit time in average population from the mouth to the end of the small intestine and the beginning of the colon is on an average of 90 minutes. There was an article published by Dr. Reed and his team back in 1985 that they have done continuous colonic infusion of lactulose into the cecum and have found that when they give 0.15 gram per minute of lactulose versus a lower dose of 0.02 gram per minute, the faster weight have yield a much higher hydrogen concentration. In addition, it looks like that it takes about 40 minutes right here to cause a rise of 20 parts per minute in breath hydrogen. So knowing this, it's we know that there's a significant rise in hydrogen by colonic fermentation, and this rise in hydrogen is not immediate after the substrate of lactose being given. So technically 90 minutes plus another 40 minutes, it could be 130 minutes after substrates given before a rise in the colonic fermentation. But the North American consensus used 90 minutes was really reasonable. And then when you see elevated baseline hydrogen level, you always wanted to check to see if the patient have followed adherence to fasting or the diet before the test, because sometimes it could be fermentation from the food that they ate before the test. And then know that methanogen can ferment anytime with or without the substrate. So therefore, based on North American consensus guideline, anything above 10 parts per minute is considered positive for methane at any time point. It doesn't have to wait for the 90-minute mark. And then another thing is that the carbon dioxide, if its measures exceeds acceptable limits. Now, remember, one thing that we wanted to know is that to know about the alveolar concentration of carbon dioxide, it is about 5.5%. And then in the air that we breathe in, and depending on what city you're in and whether or not there's, air pollution, it's average 0.04% of carbon dioxide in room air. So when you see a carbon dioxide level that is really low, it suggests to you that the sample that you got is very diluted with the room air carbon dioxide. And a lot of times the breath tracker that we have here, and it depends on what machine or what kind of breath analyzer you use. Typically, they do use carbon dioxide, and they would be able to use this measurement of carbon dioxide to normalize the breath hydrogen level to alveolar concentration as a marker to increase the reliability of correct sampling of the breath test. Now, here is a sample of reporting that we have on the left here at Cedars-Sinai. We would usually include hydrogen, methane, and carbon dioxide, as well as the corrected number here for carbon dioxide. Here is normal hydrogen, where the baseline is at 8, and then it peaked at 15 minutes to 11, and then at 90 minutes it was 4. And then as you can see, carbon dioxide at the breath measurement of the sample is 402. The machine itself corrected it with a correction factor of 1.3. Together is 5.5 if you add them together. And that is how the machine automatically corrects it. And then on the right here, it's a positive breath test based on a different reporting method using a different analyzer. And then as you can see here, hydrogen at baseline is at 8 and at 90 minutes 42. It's well above the 20 parts per minute cutoff. Here is a sample of methane. As you can see, this person actually has hydrogen because baseline is at 5, and at 90 minutes 25, there is 20 increase of rise of 20 parts per minute there. But if you look at methane, it's well under 10, so it's normal. On the other hand, on the right-hand side here, this person has elevated methane even at baseline. Now, we're going to talk about hydrogen sulfide a little bit. It is a third fermented gas. Excuse me, hydrogen sulfide is produced by sulfide-reducing bacteria using hydrogen. And clinically speaking, it is associated with diarrhea. A positive test for hydrogen sulfide level is more than 3 parts per minute at any time. Now, interestingly, both methane and hydrogen sulfide fight for hydrogen. It is rare, but it is possible that a person can have both methane as well as hydrogen sulfide at the same time. Here is a sample breath test on the left with normal hydrogen sulfide, and here on the right is abnormal. As you can see, baseline here is about 3. Now we're going to talk about interpreting results of a malabsorption breath test. Carbohydrate malabsorption when we talk about carbohydrate malabsorption, the first thing you wanted to do is to make sure you first excluded microbial overgrowth, because if you were to send somebody for carbohydrate malabsorption breath test and SIBO or EMO has not been excluded, there is a potential false positive result. And then fructose and lactose breath testing, it should be done for at least 3 hours versus the 2 hour for microbial breath testing. And this is so that we're allowing enough time for the substrate to reach the colon for fermentation by colonic bacteria. And in interpreting the carbohydrate malabsorption, a rise of 20 parts per minute in hydrogen from baseline at any time point would be considered positive. And here is a sample of lactose malabsorption breath test, where on the left it's normal. And on the right here, there is a rise, on the right here, there's a rise of hydrogen. Now, in summary, breath testing is non-invasive. It's useful in assessing microbial overgrowth as well as carbohydrate maldigestions. The most common symptom of microbial overgrowth is abdominal bloating. So when you come across a patient that come to you and be like, oh, I have a lot of abdominal pain, but the patient's not bloated, there's no complaint about gas, then chances are your differential for microbial overgrowth should be low on your priorities versus somebody who come in and say, oh, I'm bloated, and then I associate bloating with the abdominal distension, like I feel like I'm 8 months pregnant all the time, then the possibility of microbial overgrowth would be high on your differential. Breath testing should include measure of carbon dioxide to adjust to the alveolar dilution of air. Following pre-test diet instructions are very vital in optimizing accuracy of this result. And then microbial overgrowth should be excluded before breath testing for carbohydrate malabsorption to avoid any kind of false positive result. And then lastly, I want to share my pearls of wisdom from my GI motility first practitioner perspective. That number one is that interprofessional relationship is truly key to success. Whenever we deal with carbohydrate maldigestions or microbial overgrowth, we always needed the help of dietitians, nurses, physicians, MAs, medical technologists are the ones who want our breath test here at Cedars-Sinai. And then the pharmacists are the ones who help us dispense lactulose or whatever substrates and other things that we need from the pharmacy. And then if you work in a center that has research, also you wanted to work have a good working relationship with research assistants, research scientists, and other research members of the team. And then, as you know, knowledge, research, and innovation on breath testings are constantly evolving. So make sure you keep an open mind. And then for clinicians out there, make sure you take a really good history, because you know it really truly does goes a long way. And here I'm going to stop sharing my slide, and I'm ready for questions.
Thank you very much, Coco, for that outstanding presentation on breath testing. I think this should be part of everybody's library for teaching and instruction of breath testing moving forward. So we got a few questions. If anybody else want to add questions, just add it to the Q&A box on the bottom, and Dr. Cash and I will toggle back and forth to Coco the questions as they come in, and we'll try to get through as many as possible. Coco, we got one from Dr. Parkman, and he says, how does the treatment change in response to the different results of the breath test? What are your thoughts on that? Maybe Dr. Cash can add a few thoughts onto that also.
Okay, yeah, sorry, because of the limitation of time, I really didn't go over any treatment. Hopefully in the future, I would have more time and then we can talk about treatment. But treatment have been published in the ACG guideline in 2021, as well as the North American Consensus Guideline. And I don't think it's a North American Consensus, but there are other guidelines out there that also talk about treatment. Mainly, there are evidence to show that rifaximin is effective in treatment, especially those who have hydrogen predominant bacterial overgrowth. And then those who have methane, usually we use a combination of rifaximin plus neomycin, but unfortunately, neomycin currently is in back order by the manufacturer, so it's not readily available as compared to before. So therefore, we could also use rifaximin plus flagyl. And then with the newcomer of hydrogen sulfide, that's like another whole new story. But bismuth has been somewhat successful and also could be used in combination with rifaximin with bismuth, or rifaximin with flagyl has also seems to be effective.
Excellent. Dr.
All right.
Cash?
Sure. So, and I blame Dr. Pimentel for the shortage of neomycin, by the way. So I just want to go on record for that. This is a good question from Kira Rashba. Is there a reason to stop probiotics? How do you counsel your patients about probiotics before a breath test?
That's a really common one. Yeah. So with microbial overgrowth, because there's already excessive content or numbers of microbials in the small bowel, we usually do not recommend probiotics in these populations. So no probiotic, no prebiotic, no symbiotic.
Same thing for time frame before the test, 4 weeks or so. Is that what you all recommend?
If you're talking about, so if we're talking about somebody who tends to have relapses and recurrent, microbial overgrowth, it could be much longer than that, because we really don't want it to add on any more potential, agent there.
Yeah, I think the question is prior to testing. What do you tell
prior to
patients about?
testing?
Yeah, sorry, I wasn't clear. That's my
Oh,
fault.
so sorry. Yeah, so if it's prior to testing, the North American consensus that came out in 2017 did not came to what I remember. I don't think they have came through a consensus on probiotic. So there's no true recommendations on that, but technically speaking, in a clinical perspective, if patients are already on probiotic and they needed to do a breath test, we usually tell them to hold it for at least 1 week.
Excellent. This is an interesting one, Coco. Is from Victoria Pope. It says, she's a diagnostic nurse here, and she says, how does the nasal cannula oxygen affect the hydrogen breath test?
Oh, that's an interesting one. So let me just make sure I interpret this question correctly. So what she's saying is a patient is on nasal cannula with oxygen.
Correct.
And how is it going to interpret the breath test? Okay, so wow, I wish I could know about this question so I could research a little bit, but from the back of my head, there are devices that actually, instead of carbon dioxide, they could use oxygen as correcting factor, but most of the devices do use carbon dioxide. But because there is a higher concentration of delivery of oxygen through the nose by the means of that additional nasal cannula, it may bring in more oxygen to the lungs, but it doesn't mean that it may or may not interfere with the alveolar gas exchange level of oxygen and carbon dioxide. So I believe that the person who has a nasal cannula, we could collect and interpret the breath samples just as of average population.
Excellent.
All right. So I'm going to give another question, but I'm also going to put a little bit of my own flavor on this question. So it's going to be a two-part question. So the first part is my own. You gave some great advice in terms of counseling of patients and what they should do or should not do prior to a breath test. In your experience, and of course this may be regional, but I think probably universal, what are the most likely pitfalls in terms of patient compliance with performing a breath test, whether it's tobacco use prior or eating or, not eating the right diet, that sort of thing. So that's the first part. And then the second part, which is an extension of that, is how do you handle a baseline elevated hydrogen in terms of interpretation when a patient swears up and down that they were completely compliant with all of the recommendations and admonitions prior to the test?
Yeah, that's a good question. So for the first part, typically we don't see a lot of patients with issues of cigarette smoking or strenuous exercises. Typically, it's a diet compliance that we have issue with. And sometimes they would say that they never got the instruction, or some would say they got the instruction, but they misinterpreted. They thought they could put cream in their coffee. So it depends on what it is and their clinical symptoms. It may lead to your question too with the baseline elevation oxygen and hydrogen. So if I look at the breath test result, and the patient, clinically speaking, does have a lot of abdominal bloating and distension, and and like it's giving you a microbial overgrowth picture, and there's elevation in baseline hydrogen, then I would also look into, hopefully there's levels of methane, because that might pinpoint or give me some directions on whether or not this is, you know, a true positive or if it is a negative result. And then I will also look at the carbon dioxide correlation to whether or not it is a good sample from the patient. So if the carbon dioxide level is good, it shows that samples are good, there's positive clinical symptoms, and the patient swears to you that it's very compliant, it's been NPO for like 12 hours or 8 hours, then I might treat the patient as if it's positive. Because ultimately you don't want to miss a person who's suffering and then not treat them. And overall, the use of rifaximin has shown to have a good safety, excellent safety profile, and there's potentially more benefit than ways to treat.
Here's a good one. It comes up quite often is how long does it take for you to blame the symptoms with, I would guess, an elevated level of hydrogen and methane, or why, if symptoms present within the first 30 minutes after ingesting a substrate, what are your thoughts on the symptoms presenting very early in the breath test correlating with the excessive or increased hydrogen or methane levels?
Okay. Let me make sure I get these questions right. So you're saying is the substrate is injected and then the patient has increased symptoms after 30 minutes of ingesting a substrate?
Yes, yeah, really quickly after they ingest the substrate. What's your thoughts on that?
Yeah, it could be low. So my thinking is it could be multiple reasons. It could be, it depends on the symptoms. If they complain of a lot of gas and bloating 30 minutes after, one thing to my mind is whether or not there is already proximal fermentation by bacteria early on. So it could be because of whether or not there is true microbial overgrowth, and there is a lot of excessive bacteria that's causing fermentation and symptoms. So that would be the first thing. Second is that I need to look into whether or not the person actually might have rapid colonic or rapid bowel transit, and because sometimes it could bring the substrate, down much quicker than average person or population. And then I have to check on the patient and see did they forget to stop their prokinetic or other reasons that might have caused an increase in rapid transit.
So Coka, here's another interesting question. And what do you think about the home breath test kits compared to doing it in a physician or a clinician's office or a hospital setting or a clinic setting? How accurate are they? And a lot of places don't have the equipment that a tertiary care site might have. So what's the utility of the home breath testing?
Yeah, so I am somebody who advocate for like access, because like you said, there are patients who might not have access to the clinical facility. And when it comes to, the point that they could not, then the home breath test is definitely a way to go. Although there are multiple, I don't want to say many, but there are at least multiple companies that manufacture these home breath tests. And some of them may not be regulated as well as the others. So I don't know the actual sensitivity or specificity depending on the manufacturer or what kind of guideline that they follow. But generally speaking, in terms of home breath tests, we do use a couple home breath test company, and one of them assess three gases, the three gases that we talked about: hydrogen, methane, and hydrogen sulfide. And with these home breath test company, they usually give the instruction, and I believe the collection bags are different, but then they do instruct the patient to, let's say, for example, in one of the company that they instruct the patient to exhale, blow out, and don't collect the first 2 seconds, then collect the 3rd second onward to make sure that it's a good sample. So it increased the reliability.
I got a question from social media. It came in, Coco, it says, how does microbial overgrowth differ than SIBO, or is it interchangeable?
Sorry if I confused you. I used the word microbial overgrowth. It's mainly because I wanted to include bacterial overgrowth, intestinal bacterial overgrowth, which is SIBO, small intestinal bacterial overgrowth, SIBO, as well as intestinal methanogen overgrowth, IMO. So microbial overgrowth include both. And then typically with SIBO, it includes hydrogen or hydrogen sulfide, predominant bacterial overgrowth.
Thank you.
So here's a practical question. I've actually never even thought of this, but it's a great question. So, we use 90 minutes as our cutoff. Why are we going to 2 hours for the tests, Coka? Is there a reason why we prolong that beyond our cutoff time?
That's a good question. The 90-minute is the cutoff. I believe when we extend out to 2 hours, or in case if we see anybody who have, because everybody's transit time is different. Just in case if the patient's, transit time it's a little bit slower, the little extra last 2 sample will make sure that we have more as accurate of a result as possible.
This is an interesting one, Coka. I think it's probably becoming more and more relevant with people really thinking about their diets more. But this question is, my vegan or vegetarian or diabetic patients have a hard time adhering to a strict diet. Any suggestions if they can't consume the proteins?
Yeah, that's a hard one. And usually this is the part where I say interprofessional relationship is key, because usually I will rely on our dietitian to see, is there any suggestions on alternative? Because if they cannot do one protein, perhaps can they do another alternative protein, or what can they do? If somebody who's absolutely cannot tolerate anything that's, that's good, then we would use the least or minimal fermentable product out there to be as close as possible. It may not be perfect, but it is what it is, in a way.
Where you try and ask your dietitian to help you out, I guess.
Yeah.
If you have a dietitian. So, another question that kind of is a direction from one of the previous questions in your answers with regards to transit time. So at least at our place, when I order a breath test, I often will get a small bowel transit study to try and calculate that small bowel transit time and see when the substrate hits the cecum. What's the data on that? Is that something that you recommend? Is it worthwhile? Is there strong enough data to make that a standard practice, or is that just, still somewhat out there?
Yeah, Dr. Cash, you're really putting me on the spot here, because I think you and Dr. Baker and Dr. Vern, you all know that there's so much controversy out there, and even a lot of the consensus guideline cannot come into a general consensus about that. Even the North American consensus guideline did not really agree on using the hydrogen breath testing to estimate oral sacral transit time. So to answer you clinically speaking, our center, we do not do a separate transit study just to get the transit time. I think it's a controversial topic, and that's all I know.
I think you've got a future in politics.
Yeah, maybe we should include or invite Dr. Pimento and see what he thinks.
Well, we're running out. This has been a great conversation, and the conversation will continue on the questions that we didn't get to on Doc Matters. Like to thank Coco and Dr. Cash and Dr. Vern and all the people, team Stephanie and Lori, to putting this on. And Coco, in the last maybe 30 seconds, I know you talked about your slide of the pearls of wisdom, but if you can give your pearls of wisdom again to stimulate the next Coco out there for their labs.
Yeah. So to highlight, interprofessional relationship is really important. So make sure you work well with the team that you're working with, because one day you never know who you're going to need help from. And honestly, I got some of the breath testing pearls from our medical technologist who does our breath tests, or how do you know I know about the carbon dioxide, and and he even told me the little tube that goes in front of the machine that after you put the syringe in is there to reduce condensation, because I didn't know that until I talked to him. So make sure you have a good working relationship with your team. And then for the students or for those who are new to GI motility or breath testing, make sure you take a really good history, because sometimes we come across patients who may not even have the abdominal bloating or signs and symptoms for it, and then their chief complaint is abdominal pain. Then you probably want to think of something else, because it may not be microbial overgrowth or carbohydrate malabsorption that's causing the pain, but something else. So differential mainly come from partly from your history. So take a really good history on that now, because that will lead into a whole new different kind of workup. And then lastly, just keep an open mind. Anybody who's, learning new things, especially a few years ago when I first came into GI motility, and when I learned about breath testing, it seems like, oh my God, there's so much information, and there's always new information. There's always new innovation. So just keep an open mind. There's always new stuff. And what we're talking about today may not be the same case, a few years later. So.
Perfect. Well, thank you, everybody, tonight, and hope this is helpful. And I really hope everybody uses this for their teaching programs at their own institutions. Thank you for everybody who put this on, and have a good night.
Have a good night. Thanks for having me.
Thank you.